Good afternoon from Atlanta. Thank you for joining our Enhanced Barrier Precautions and Skilled Nursing Facilities webinar. My name is Kara Jacobs-Slivka. I'm a medical officer at the Centers for Disease Control and Prevention and lead our long-term care team, our long-term care focused efforts. I will be your moderator today for our talk. Your presenters are Dr. Heather Jones, Dr. Bola Ogundimu, and Ms. Linda Behan. Dr. Jones is a nurse consultant, and Dr. Ogundimu is a nurse infection preventionist, both with the long-term care team within the Division of Healthcare Quality Promotion at the Centers for Disease Control and Prevention. Ms. Behan is a nurse infection prevention consultant who has served in a senior infection prevention role with a large corporate nursing home healthcare system, having made significant contributions to infection prevention through the Association for Professionals in Infection Control and Epidemiology, or APIC, and her state healthcare association. She has previously collaborated with the CDC on the implementation of enhanced barrier precautions in skilled nursing facilities. We do not have any disclosures. The next few slides include our continuing education information. I will let you read through all of these slides. Although the CDC is accredited by the Accreditation Council for Pharmacy Education as a provider of continuing pharmacy education, this webinar is not accredited for pharmacists. I will also share this CE information, including where you can go to obtain CE credit over the next 30 days, again at the end of this presentation. All participants will be muted during the webinar, so please feel free to add questions in the Q&A section. And at the end of the presentation, we will have some time for questions, although we may not be able to get to all of them. This webinar will be recorded and will be made available on our Enhanced Barrier Precautions website. So the objectives for today's webinar include a description of enhanced barrier precautions, which will be preceded by a brief review of standard precautions and contact precautions in order to allow for comparison between them. A discussion of why enhanced barrier precautions are recommended to be used in nursing homes, and a robust explanation of methods for how to be successful with the implementation of enhanced barrier precautions in your facility. We will spend much of our time describing lessons learned through the process of implementing EBP across nursing homes and how this information can be helpful and can help you begin the process of preparing for and using EBP at your facility. And so with that, I will hand off the presentation to Dr. Heather Jones.
For almost 3 years, many of us have been using precautions geared toward reducing the transmission of SARS-CoV-2, the virus that causes COVID-19. And before we get into our description of enhanced barrier precautions, we are going to provide a brief review of standard precautions and contact precautions. So standard precautions are used in all settings and with all residents, not just those who are considered high risk. It is in place to protect you and the resident. Standard precautions are based on an assessment of risk in order to protect healthcare providers from contamination and to prevent the spread of infection between individuals, such as resident to resident, staff to resident, or vice versa, or through shared equipment. Standard precautions include all of the following practices you see on this slide. One component of standard precautions I would like to further review is with the use of PPE, or personal protective equipment, when there is an expectation of possible exposure to infectious materials. Gloves should be worn whenever there is a reasonable anticipation that you could come into contact with blood or other potentially infectious materials, mucous membranes, non-intact skin, or potentially contaminated intact skin. For instance, if you are providing care to a resident who is incontinent of stool or urine, you could reasonably anticipate contact with body fluids, so gloves and possibly even a gown should be worn. Gowns should be worn during any type of procedure or resident care activity that may involve contact with blood or body fluids, secretions, or excretions, and masks, goggles, or a face shield is recommended to be used during any activity likely to generate splashes or sprays with blood, body fluids, secretions, or excretions. Now, contact precautions are a type of transmission-based precautions, which are used in addition to standard precautions for residents with known or suspected infections that can be spread via direct or indirect contact. The use of gloves and a gown are required every time someone enters a resident's room on contact precautions and for all activities performed in that room. Ideally, residents on contact precautions should be placed in a private room and restricted to his or her room except for medically necessary care. The intended duration of contact precautions is for a limited time frame only in order to prevent transmission during an infectious period. Prolonged contact precautions can be very isolating if used for long durations of time. Contact precautions are the infection prevention and control approach that are used by most healthcare settings, including acute care hospitals and long-term care hospitals, to prevent the spread of multi-drug resistant organisms. So what are enhanced barrier precautions? Enhanced barrier precautions, or EBP, are infection prevention practices that take a risk-based approach to reduce the spread of multi-drug resistant organisms, or MDROs. Like contact precautions, EBP should be used in addition to standard precautions. A gown and gloves are used during what we call high contact resident care activities for residents at high risk of colonization with an MDRO in order to disrupt spread. By focusing on high contact resident care activities, which include close contact, hands-on care provided in nursing homes, EBP expands the use of PPE beyond situations in which exposure to blood or body fluids is anticipated. During high contact care, the hands and clothes of the healthcare personnel can become contaminated with MDROs. This can then become a source for transmission to other residents. It is important to remember that EBP is intended to be used with good infection prevention and control measures. High contact resident care activities include all of the following: dressing, bathing or showering, transferring, providing hygiene, changing linens, changing briefs, or assisting a resident with toileting, indwelling medical device use or care, which may include, but is definitely not limited to, an indwelling urinary catheter, a tracheostomy or ventilator, central lines, or a feeding tube, and wound care, which is generally defined as the care of any skin opening requiring a dressing. When we discuss wound care in the context of EBP, we do not generally mean the shorter lasting wounds, such as skin breaks or skin tears that would be covered with a Band-Aid or similar dressing. We tend to refer to these as more chronic wounds, which may include, but are not limited to, pressure ulcers, diabetic foot ulcers, unhealed surgical wounds, and chronic venous stasis ulcers. These high contact resident care activities are often bundled together as a part of morning care or evening care and performed in the resident's room. These activities were chosen from nursing home studies that measured the risk of transmission of MDROs between residents and staff. While some of these activities, such as bathing or showering, are high contact, whether they are bundled with other activities or not, others may not necessarily be considered high contact if performed alone, such as helping a resident put on a sweater or brushing a resident's hair. Enhanced barrier precautions should be used with residents who have any of the following present: an infection or colonization with an MDRO, as there is risk of staff becoming colonized and spreading the MDRO to other residents; wounds or indwelling medical devices, as these residents are at higher risk of becoming colonized with an MDRO. The goal of EBP is not to use PPE for every single resident nor every activity, but to protect the most vulnerable of our nursing home residents during the highest risk activities to reduce the spread of MDROs across the entire facility. What do we mean when we say when contact precautions do not apply in our EBP guidance? We mean that there are some situations in which contact precautions should be used and EBP should not, such as for any residents infected or colonized with an MDRO who also have the presence of acute diarrhea or draining wounds, or other sites of secretions or excretions that are unable to be covered or contained, as these individuals may be much more likely to spread the MDRO, or for a limited time period on units or in facilities during an investigation of a suspected or confirmed MDRO outbreak. This also means any resident who otherwise meets criteria for the use of contact precautions, such as those with C. diff, norovirus, or scabies, should use contact precautions instead of EBP. EBP should be used for the following MDROs that are targeted by CDC, such as pan-resistant organisms that have no current treatment options available, and organisms that have limited treatment options, such as those listed. EBP guidance provides the flexibility to work in conjunction with public health to determine the most appropriate MDROs for which EBP should be implemented. Some additional epidemiologically important MDROs are shared on the screen for reference. For enhanced barrier precautions, the use of gown and gloves is only recommended when high contact resident care activities will be performed, such as during bundled AM or PM care. A resident on enhanced barrier precautions does not need to be in a private room, and there are no restrictions to participation in group activities, including communal dining. Enhanced barrier precautions are recommended to be used for the resident's entire length of stay in the facility. Listed here are some of the main differences between contact precautions and enhanced barrier precautions, such as when to use gown and gloves, private room use, room restriction recommendations, and the time for precautions to be in place. You will notice that contact precautions is more restrictive for both residents and healthcare personnel than enhanced barrier precautions. Earlier, I discussed good infection prevention and control measures are needed in coordination with the implementation of EBP. I would now like to discuss a few of these measures in detail. Over the next several slides, I will talk about each of these: hand hygiene, or cleaning your hands, PPE use, environmental cleaning and disinfection, auditing, and communication. Each have an integral part in a successful implementation of EBP. We all know what hand hygiene is, but are we reliably performing appropriate hand hygiene? Use of alcohol-based hand sanitizer is recommended prior to and after performing any hands-on activity with a resident, as well as both before and after donning or putting on and doffing or taking off gloves, including and especially with high contact resident care activities. You are recommended to use soap and water if your hands are visibly dirty before eating and after using the restroom. The use of PPE, or personal protective equipment, is vital, and we all know now how to appropriately don or put on and doff or take off. It is important to review when and what types of PPE are recommended during activities with residents, and to ensure your staff have continuous access to PPE at point of care locations. Environmental cleaning and disinfection include many elements, but here are some of the more important components. Develop and maintain a who cleans what list. Clean and disinfect high-touch surfaces such as handrails and doorknobs at least daily. Try to reduce the number of cleaning and disinfection products used. Many EPA-approved products do both and can help eliminate a separate cleaning step. And clean and disinfect any reusable medical equipment between use with different residents, including with vital sign machines, radiology equipment, bladder scanners, glucometers, and transfer lifts. For any of the previously mentioned measures to be successful, monitoring adherence to IPC practices is one of the most consistent ways to know how your facility is performing on infection prevention and control measures. You can choose to provide auditing either electronically or by paper, but whichever way you choose, providing real-time feedback is also important. With communication, use signs that are visible and legible. It is best not to only use a "Stop, See Nurse" sign on a resident's door, as staff will not understand what precautions need to be taken prior to entering the room. Also, make sure the facility maintains an up-to-date list of residents who meet criteria for precautions. When you are communicating to another unit, floor, hospital, doctor's office, or even to your health department, it is important to discuss MDRO status and any precautions recommended to be used for the resident prior to transfer, whether this is a resident leaving your facility or a resident being received at your facility. Knowing a resident's status can immediately reduce the potential for MDRO transmission. Include your entire team, both internally and externally, with communication. I am now going to turn over to my colleague, Dr. Bola Ogundimu, to help with understanding why we recommend the use of enhanced barrier precautions in nursing homes.
Thank you so much, Dr. Jones. So, enhanced barrier precautions, as Heather was starting to talk about earlier, for the next slide, are needed for nursing home residents due to the presence of a high burden of MDROs, as some may be aware. So there are many facilities that may not know the residents are colonized with MDROs, and colonized residents are at an increased risk of MDRO infection. So again, colonization happens, or it means when an organism or a germ is found somewhere in or on the body, but it is not causing any signs or symptoms of any illnesses or sicknesses. Where an infection, on the other hand, is when the organism is causing symptoms of an infection. And MDROs can spread between residents as well as to healthcare personnel, whether residents are colonized or infected with the MDROs or not. So EBP provides a method for reducing transmission or spread of MDROs without isolating the residents, and it allows for a balance between resident quality of life and resident safety. So, while many of our nursing home residents have complex medical needs, as you may be very well aware, and they could also be at a higher risk for acquiring MDROs, we do realize standard precautions a lot of times is not often consistently and successfully implemented in nursing home settings. So EBP adds a PPE-focused approach to other infection prevention activities and allows for a more effective response to serious antibiotic-resistant threats or antimicrobial resistance in nursing homes, while reducing the need for prolonged use of contact precautions, as Heather alluded to earlier. So, by nature, we realize that our nursing home residents are often older adults with a couple of risk factors for infections. So those risk factors could include a decreased immune response due to natural aging, also comorbid conditions, many of which are a lot of times complex, and then deficits in functional as well as cognitive status, leading to a higher level of dependence on healthcare personnel, as well as frequent antibiotic use and also increase in the use of indwelling medical devices, a lot of times in our nursing home residents. So we looked at the literature, and I'll be going over a couple of literature reviews that we've done. So the first is from a 2020 publication, and it provides information on the high prevalence of MDRO colonization in 28 nursing homes in Southern California. It provides a context for our concern for the silent spread of MDROs and the reason for a recommendation of EBP in nursing homes. So for this study, almost half of the residents, as you can see in the figure on the right-hand side with the iceberg, almost half of the residents were found to be colonized with MDRO, only found during screening. But only 4% of those residents had an MDRO documented in their records. So that's pretty surprising. It was surprising at the time. We realized that the comparison of this study maybe to an iceberg is very appropriate, in that what we see or know a lot of times may be different in terms of MDRO colonization, may be different from the actual burden of MDROs at our facilities. And so we realize, also published in this study, that factors associated with MDRO colonization included the presence of indwelling medical devices, as well as residents being bedbound. So this further highlights the importance of EBP, and it explains, it expands interventions to address the silent spread of MDROs in our nursing homes by applying interventions to residents who are not known to be colonized or infected with an MDRO, but who would be or who might be at a higher risk for MDRO colonization in those settings. So the next sets of studies highlight two different studies. So the top study from 2015 was with residents as well as healthcare personnel from 13 nursing homes in Maryland and Michigan. And it showed that high-risk activities for gown and glove contamination with MRSA included dressing residents, transferring residents, as well as providing hygiene and changing bed linen for residents, in addition to toileting residents. It also noted that residents with chronic skin breakdown had significantly higher rates of gown and glove contamination in this study. And then the bottom study from 2017 also involved residents as well as healthcare personnel from VA nursing homes. And it showed that high-risk activities for gown and glove contamination, this time for resistant gram-negative bacteria, included indwelling medical device care, as well as assistance with hygiene, as well as toileting and bathing activities with residents. So again, high contact resident care activities, inclusion in enhanced barrier precautions considerations were directly informed by nursing home research that identified these high-risk resident care activities for MDRO transmission. So also we had another study, this time a little bit more recent study from 2020, and it was conducted in 2 nursing homes in Maryland, and it included residents in short stay as well as long stay units. And it found that MRSA acquisition, that is denoted by the gray bars in the figure, decreased during the nursing home residents' inclusion in the study. And so the activity with the study included the healthcare personnel being monitored for adherence to targeted use of gown and glove use. And so if the adherence was shown to be excellent, meaning pretty high adherence, it was correlated with having less transmission of MDROs, essentially. So the higher the adherence, the less the transmission of MDROs in this case. We are still continuing to undertake additional studies, and we're going to continue to provide support as we go into our ongoing studies to understand the most effective approaches to preventing MDRO spread in our nursing homes. Also, enhanced barrier precautions helps maintain a home life environment for our residents. As Dr. Jones shared earlier, residents on enhanced barrier precautions do not need to be restricted to their rooms. They can go to group activities, and they can have meals with their family members as well in the dining room. So it's less restrictive. So while we do see an increased use of PPE, enhanced barrier precautions allows for a more balanced approach to resident quality of life and safety from the spread of MDROs, and also potential for serious infections. So by providing less restrictions while maintaining a method for reducing the transmission of MDROs, we can continue to provide our residents with a good quality of life. So lastly, this slide talks about our HICPAC group, which is the Healthcare Infection Control Practices Advisory Committee. So CDC a couple of years ago had asked the HICPAC group to provide infection prevention advice and guidance to CDC. And so they convened a work group of long-term care experts to review available literature and develop an expert consensus on the use of enhanced barrier precautions. And there's a link to the white paper that was developed by this work group in our Enhanced Barrier Precautions, on our Enhanced Barrier Precautions page. And it voted in support it was voted in support by HICPAC, and so it can be found in that resource section. It's at the end of this presentation under the resources link. And so the HICPAC group summarized that EBP is an approach of targeted gown and glove use during high contact resident care activities that is designed to reduce the transmission of MDROs, which may be applied for residents with wounds or indwelling medical devices, as well as residents with infections or colonization with an MDRO. So I will now turn over the presentation to our guest, Linda Behan, who was introduced earlier. She will walk you guys through enhanced barrier precautions pilots and her implementation of those practices in her multiple nursing homes. Thank you. Linda?
Thank you. Prior to becoming a consultant, I worked as the corporate infection preventionist at a large nationwide long-term care company. As stated earlier, we collaborated with the CDC in conducting a pilot project focused on implementing enhanced barrier precautions facility-wide in 10 of our facilities. The number of beds per facility ranged from 106 to 238. 9 facilities had short stay rehab units along with traditional long-term care units. One center was total short stay. It had all private rooms, and we also had 2 facilities that had ventilator units. The EBP criteria used was colonization or infection with any MDRO and or having wounds and or indwelling medical devices. Now, the project plan consisted of 2 to 4 weeks for implementation and then 3 months of intervention. The specific outcomes we were attempting to measure included staff adherence to EBP, staff, resident, and family member feedback, description of residents meeting EBP criteria, changes in hospitalization and infection rates, and also burden, including cost. Now, having buy-in or support from the medical, clinical, and operational leaders of your facility is absolutely crucial for a successful implementation. They will need to understand not only what EBP is and why it's important, but also the impact of implementation. I believe as infection preventionists, we can certainly explain the rationale of EBP and how it will benefit the residents, but also admissions and potentially costs to the facility through decreased MDRO infections and hospital transfers. We can explain colonization pressure, meaning the higher the number of residents on a unit or in a facility that already have an MDRO, the greater the risk for new admissions to acquire it. Therefore, controlling the spread of MDROs will make it easier to cohort new admissions and avoid the frustration of bedlock or inappropriate cohorting. At the very beginning of the project, the medical director was brought into the center planning, and a letter to medical providers was sent explaining the project since they are important partners and their participation was necessary. This is something you may want to consider also as you begin EBP in your facilities. We knew that if we followed traditional approaches to implementing EBP in the facility, such as holding an on-unit in-service, where the staff is educated on a new policy and procedure and given a target date to have it implemented by, the process would fail and not be sustainable. That method would be fine for something small, but EBP has many facets to it. So we decided on a QAPI approach, specifically using Plan, Do, Study, Act. This would allow a systematic, slower implementation of EBP and give us the ability to learn lessons from each unit it was implemented on. Just as you would develop a lesson plan for an in-service you're providing, development of an in-depth implementation plan is vital. The implementation plan should cover every aspect of implementation. For example, planning. Develop a QAPI subcommittee to develop the implementation plan and oversee the implementation process. Decide which unit EBP will be implemented on first. This should be the unit with the greatest number of high-risk residents. Following the first unit rollout, determine the order of all additional center units. Establish a target date for having EBP implemented facility-wide. What about education? How will training be conducted? Who will provide the training? How will all necessary healthcare workers, residents, and families be reached through the training? How will questions be answered? How will the effectiveness of training be measured? Who's going to order and then stock the supplies? And what will be the location of precaution signs, the PPE carts, ABHR dispensers, and disinfectant wipes? It's important to identify residents with qualifying characteristics for placement on EBP and to maintain this list. The facilities were required to review the progress with implementation as a standing agenda item in QAPI until it was fully operational and habitual. Here is an example of the PPE section of the implementation plan we developed. Notice the detail of the plan and the reminders in the comment section. Crucial to the success was resident family education, which was done not only at the beginning of implementation, but also done for all new admissions. It was important for residents and their families to understand why someone that had not been on precautions was now being placed on precautions, how it would or would not impact them in their care, and to allow for questions. All in all, it was well received by the residents. No one refused, and for the duration of the project, no one voiced concerns about feeling isolated or the precautions negatively affecting them. What we did learn was that if education was not provided timely, staff reported residents and their families would begin to express concern and ask if they had developed an infection when EBP was initiated, at which time education and reassurance was provided. Many residents and families were actually pleased because they were on precautions in the hospital and/or they felt it provided them more protection. We learned from an experience in one of our Washington state facilities. There, the local DPH assisted the center in implementing EBP due to identification of carbapenemase-resistant Acinetobacter baumannii, better known as CRAB, in the center. It was then that the state surveyors came in for survey, and of course, they immediately became concerned with what they were seeing. They initially assumed there was an infection control problem, but once they were informed of the facts and circumstances, it was no longer an issue. Therefore, we created simple talking points and had the facilities contact their local state surveyor offices to inform them of the project. Many thanked the center for the call and heads up and even expressed interest. You can see some of the issues identified regarding the isolation carts on the slide, such as concern about clutter in the hallways and the number of carts required. A best practice we found was to use one cart per 2 to 4 rooms, depending on the style of the cart. Several of our facilities identified a generic cart from a national retail chain that was slimmer and wider and could accommodate twice the amount of PPE. If you can have affected residents in rooms close to each other, that is optimal. Life safety and ADA issues must be considered, as some facilities wanted wall-mounted PPE containers. Keep in mind that life safety and ADA codes include different requirements. So this required us to educate and send information to facilities. So let's take a look at life safety code. Projections into the corridor for wheeled equipment are permitted under 3 conditions. They cannot reduce the corridor width to less than 5 feet. You have to be able to relocate the equipment in an emergency, and wheeled equipment is limited to equipment that is in use, and they specifically include isolation carts. So make sure they're on wheels. As always, you cannot block access to emergency equipment, fire and smoke door operation, or access to exits. In terms of ABHR in resident rooms, almost all the facilities at the time expressed concern surveyors may feel there's a lack of supervision and consider this a hazard and therefore issue a citation. This did not happen. We know that CMS has expressed their support for ABHR in resident rooms. Easy access to disinfectant wipes is needed to foster compliance. Some facilities had success with placing the disinfectant wipes in the bottom drawer of the cart. Of course, it depends on the size and the type of container used. Others found that this did not work as the containers leaked. On this slide, you can see the ABHR education that was created. The memo from the state of Pennsylvania to encourage the placement and use of ABHR was also helpful. In the beginning, concerns were expressed about the amount of cumulative time for staff to comply with donning and doffing PPE. In interviews with staff after adjusting to the routine, they all said they did not feel it created issues for them. What they did say was that the key they learned was to plan ahead and bundle care. One vent center needed to increase their garbage pickup as once weekly was not sufficient due to increased trash from EBP. The other vent center did not have this issue. Some facilities ordered larger trash cans with lids for resident rooms to accommodate more PPE. Continuous education and reinforcement was required. It's important to develop discipline-specific education for nursing, rehab, and environmental services, and to improve communication with staff as to who was placed on EBP. It was a challenge to implement EBP for some of our IPs due to competing demands. The pilot was at the same time of year as the influenza program was also being implemented. There were staffing concerns, and some were expecting state survey at any time. Frequent staff observations of hand hygiene and PPE use were made on all shifts by IPs, IP shift coaches, and managers, supervisors. All disciplines were observed, including medical providers. This allowed for just-in-time training and reinforcement. Here is a representative sampling of both staff and resident comments. You can see the evolution in comments as the project went on, from feeling EBP was cumbersome to building it into staff workflow and it not being an issue. Let's talk about what we learned during the course of the project. First, in terms of staff adhering to EBP PPE use at the time of room entry. Most of the time, the staff did wear the required gown and gloves. You'll see that EVS staff had the lowest compliance rate and needed additional coaching. For hand hygiene compliance, most staff used ABHR during the observations. Although hand hygiene was performed overall well, more work was needed to be done to reach 100% compliance. When we looked at the breakdown of residents who met EBP criteria and why, we found that Of the 319 total residents, 43% had wounds, 47% had an indwelling device. In terms of MDROs, only 4% had a novel or targeted organism, while 44% had any other MDRO. Many residents had more than one indication for being placed on EBP. This should provide you with an idea of what you will see in your facility. As would be expected, facilities with ventilator services had the largest percentage of residents that met EBP criteria, 42%. Next, facilities that had mostly long-stay residents had the second largest number of residents on EBP, 28%. Our one facility that was totally short stay had the fewest number of residents on EBP, only 9%. In terms of cost, there was an increase in costs associated with more use of PPE. What we found was that the startup costs were greater than the maintenance costs. And that makes sense because we needed to purchase more PPE. Therefore, we needed to purchase more storage carts, ABHR. We also found that your costs can actually differ from actual use. And it was challenging at times to actually predict PPE use. And so supply purchases may have been an overestimate in the beginning. Some recommendations from the administrators were to spread out implementation if challenges arise, whether it be from budgeting or whatever. And we did find that the increased trash pickup was an unexpected increased cost, but again, that was at one ventilator center. So what we learned was that enhanced barrier precautions can successfully be implemented facility-wide in nursing homes, but you have to have a strong but adjustable implementation plan. You have to promote education because that really plays a critical role, not only in implementation, but also acceptance of EBP and changes in PPE use. Communication with staff, families, and residents, and even the surveyors help to create a smooth process. Applying EBP broadly across nursing homes can result in about a 20 to 30% of residents meeting criteria. We saw it was higher in ventilator nursing homes. Ventilator-capable nursing homes did have the largest costs associated with implementing EBP broadly, but they also provide care for the highest risk residents. I will now turn the presentation back over to Dr. Slifka.
Thank you so much, Linda, and thank you so much to all of our speakers. We are going to move on to the question and answer section of the webinar. As a reminder, all participants are muted, but please go ahead and type questions as you have been doing into the question and answer section, the Q&A section. And I'm going to go ahead and start. I'm going to go ahead and start with a couple of questions. So a first question here, and this kind of goes back to some of the information shared at the beginning of the presentation. How are enhanced barrier precautions different than contact precautions?
So I'm happy to take that one, Kara. So contact precautions are a recommendation for the use of gown and gloves for every entry into a resident's room. And this is regardless of the level of care that is going to be provided to the resident. These residents typically also have dedicated equipment, so stethoscope, blood pressure cuff, and they should be placed in a private room. When private rooms are not available, some residents, such as residents with the same pathogen, may be roomed together. The residents also need to be restricted to the rooms. except when they have medically necessary care that needs to be provided outside of the room. And residents on contact precautions have the restriction from participation in group activities. And contact precautions generally are intended to be time limited. And when they are implemented, should be included in a plan for discontinuation or de-escalation. Now, on the other hand, enhanced barrier precautions are the recommendation for the use of gown and gloves only for high contact resident care activities, unless, of course, other PPE would be indicated as part of standard precautions. So residents are not restricted to their rooms. They don't need to be placed in a private room. And these residents on enhanced barrier precautions are also allowed to participate in group activities. Because EBP does not impose the same activity and room placement restrictions as contact precautions, they are intended to be in place for the duration of a resident's stay or until resolution of the wound or discontinuing the indwelling medical device that placed them at that higher risk in the first place.
Thank you, Heather. I've seen a couple of times in here requests for clarification about things like skin tears. So people who have residents with skin tears or, might need something like a Band-Aid to cover a small wound, and whether or not that's included in the definition of wounds when we talk about the criteria for EBP.
Thanks. And Kara, I can take that.
Awesome. Thank you, Bola.
So we have had that recurring series of questions regarding skin tears and what kind of wounds would be classified as needed for enhanced barrier precautions. So to answer your question, it is a no because of the skin tear and Band-Aid requiring nature of a small wound. So in the guidance, we noted that wound care is included in as high contact resident care activity, and it is generally defined as the care of any skin opening that requires a dressing. However, the intent of enhanced barrier precautions is to focus on residents with the higher risk of acquiring an MDRO over a prolonged period of time. And this generally includes residents with more chronic wounds and not those with like shorter lasting wounds, such as the skin tears, skin breaks, or any minor wound that can be covered with a Band-Aid or any similar dressing. So examples of chronic wounds would include pressure ulcers, as well as diabetic foot ulcers, unhealed surgical wounds, and chronic venous stasis ulcers.
Thank you, Bola. And just one, I think, related question. Would EBP be required for a resident with an ostomy?
Yeah, that's a great question. We also have gotten quite a few of those questions. So as we have described in our enhanced barrier precautions page, wounds, again, are generally defined as any skin opening requiring a dressing with a focus on chronic wounds. So an ostomy or a colostomy or ileostomy would not be considered a chronic wound and would not meet the indication for EBP.
Thank you, Bola. And I do want to ask, this question that came in, I think may be a good question for you, Linda. The question was really around, the concern that residents might feel stigmatized by EBP. And if you could describe a little bit more about how you shared information about EBP with residents specifically.
Sure. So our resident and family education did not focus specifically on EBP. Instead, our education focused on the facility having a culture of resident safety. Now, the education that was shared with the residents and families let them know that, they may see our staff wear PPE, such as a gown and gloves during care, such as the bathing, dressing, toileting, etc. And we do this following CDC recommendations for certain standards of care and our commitment to protect them from the germs of the last resident we cared for. So we decided to use the analogy of a honeybee traveling from flower to flower, picking up and depositing pollen. And we did not want our staff to be like honeybees. So in our pilot, we did not have any residents, like I stated earlier, refuse to participate, and nor did any residents voice concerns about feeling isolated or the precautions negatively affecting them.
Thank you, Linda. You know, I've seen a couple of questions in here that have referenced to, you know, what if our facility doesn't have a vent unit? We made mention a couple of times about ventilator units or about some of the specifics in facilities that have a ventilator unit, but what if you don't have any ventilators in your facility? I'm wondering, Linda, if you could comment on recommendations for how you approach implementation, you know, or where to implement EBP first in facilities that don't have a vent unit.
Sure. So as you know, all of you may or may not be aware, CMS requires facilities to have a QA or quality assurance and performance improvement group, and they're to help identify vulnerable areas of your facility and help to develop plans or projects to support improvements in these areas. And so this is something that your QAPI work group should determine when developing your implementation plan. So I recommend you start on the unit with the highest level of residents at risk, and because they're the ones that we really want to protect as soon as possible. So, you know, take a look at the residents on each of your facility units to determine how many people meet criteria for EBP, which includes residents who are already colonized or infected with an MDRO, residents with indwelling medical devices or with wounds. Also consider in any of your units if you have a higher population of dialysis or oncology residents that may have additional risk factors, such as recent hospitalizations or antibiotic use for MDRO acquisition.
Thank you, Linda. We've reached the end of the webinar. I want to take this time to again thank our speakers, Dr. Heather Jones, Dr. Bola Ogundimu, and Ms. Linda Behan for their presentations. We are also excited to share some additional resources that will soon be posted to our website, such as this brief 3-minute video coming soon that was created in collaboration with CDC's Project First Line and introduces enhanced barrier precautions. We do have some resources at the end of the webinar that cover enhanced barrier precautions, as well as some additional educational resources, hand hygiene, and personal protective equipment. And as well as some additional references. And the slide that I want to leave you all with is information about how to access CE. This link will take you to where you need to go, and the course number and access code as well as expiration date is listed here. So thank you so very much for joining us today.